logged on?
Hmm.
YouTube, watch Howard Medical Lab. You're logged on, right?
Hmm.
You're live. Are you live?
Is it 7?
6:59. Why is your screen blank?
Hmm?
Why is your screen black?
I don't know, Tony. I'm live.
Let me try again.
Good evening, everybody. I welcome you to my YouTube Live. I'm Dr. Howard Elkin, the medical advocate. And February is American Heart Month. So I'm so pleased to have you join me tonight. We're going to dive right in because I have so many things to talk about, but we're going to focus on a very common rhythm disturbance at what we call an arrhythmia and what's called an atrial fibrillation, which I know many of you have heard. Now, some of you may follow me on Facebook and also Instagram, social media, and you probably saw a blurb that I wrote about a week or so ago. It talked about the association between atrial fibrillation and alcohol. Now, we've known for some time that alcohol could be a precipitating cause of atrial fibrillation, or association with atrial fibrillation. What we didn't know until the study came out was that it can actually be a causative factor. And this is really a very small amount of alcohol, small to moderate. The amount of alcohol used was 12 grams, which is about enough in about 4/5 of a glass of wine, less than a can of beer, and 1 shot glass of whiskey. And they found that even 2 grams of alcohol, which is really a small amount, could even make a difference in causing AFib. And they studied 104,000 subjects over a period of over 10 years. So it was a big study published in the European Heart Journal. So that was a good, important find. But the prevalence of atrial fibrillation is huge. It's seen in 2.7 million people in the United States alone, and that is estimated to grow to about 12 million by 2030 with the aging population. So it's a big problem. So when we talk about causes of atrial fibrillation, we first want to look at the obvious, which is structural heart problems. So it's really important that these patients be evaluated by a cardiologist. So we want to look for the typical hypertension is probably the most common, and I think probably 80 million or more people in this country have atrial fibrillation, many of whom don't even know it. Also, valvular heart disease, oftentimes we say mitral valve disease, can be a cause of atrial fibrillation, previous heart attack, open heart surgery, and also heart failure in itself. So all these can be structural reasons to develop atrial fibrillation. Other causes include pneumonia, COPD or emphysema, obstructive sleep apnea, that's a big one. So oftentimes we have to rule out sleep apnea. Thyroid disease, specifically hyperthyroidism. And then we have the regular triggers such as alcohol, which I've mentioned, also tobacco, and stimulants such as even caffeine can be a causative factor. So what about the risk factors? Well, one is age, and atrial fibrillation is the most common arrhythmia seen in those over the age of 70. So that age is number one. However, it can be seen in all age groups. I had my best friends in their early 50s develop atrial fibrillation. We're talking refractory atrial fibrillation that required a procedure called ablation. So it happens in people at all ages. I even had a 29-year-old who was an athlete who developed atrial fibrillation about a year and a half or so ago, who I had to eventually send for an ablation. So it crosses all ages. It's most frequently seen in men, although certainly we see it in women as well. there is an association between atrial fibrillation and high stress, oftentimes diabetes, obesity, the typical things that we see with cardiac patients. Also exercise, over-exercise and overtraining can be associated with atrial fibrillation. And one that I'm really interested in is, we call it autonomic dysregulation. Now, when I try to do a bicep curl, I'm using my voluntary nervous system to do an action. But we have this autonomic nervous system, which allows us to breathe without thinking about it, and also for our heart to beat. But it's got two components: the sympathetic nervous system, which is your fight or flight. Then you have your parasympathetic nervous system, which is your Zen-like, more to slow things down a bit. So normally there's a balance between the two. We like to think that, but in real life, we're going through so much stress that there's very little balance in today's world. So probably a large percentage of atrial fibrillation is based on sympathetic overdrive, and there's about a 30% or more that's related to increased vagal tone or parasympathetic. So the way to get that about is to ask your patients, okay, does this happen when you're sleeping? Sometimes I have one patient that they've had multiple bouts of atrial fibrillation while sleeping, which makes me think it's vagal mediated. So there's not a lot of research on this. There is research, but we haven't really utilized it to our advantage, which I think is really important and interesting. The symptoms, you probably know these by now: your heart's pounding, palpitations, chest pain, shortness of breath, dizziness. Non-specific, but probably the most common one is your heart's pounding, and it's a very scary experience. And the consequences is what really makes this arrhythmia so important. And the most important consequence of all is stroke. People with AFib are about 5 times more likely to develop a stroke than those without it. And that really is the most important consequence, the deleterious consequence. And that's the reason why these patients must be anticoagulated to prevent a stroke. And here's how it happens. You have the upper and lower chambers of the heart, and the heart's beating irregular. So there's a chance for blood clots to form in the left atrium, the upper chamber, and because the blood flow is sluggish in that chamber. And what can happen without any warning is that a little blood clot can break off, go down to the left ventricle, go up the aorta, up the carotids, and cause a stroke. So that's a pretty much dire consequence. Another big problem is fatigue. I mean, overwhelming fatigue, because the upper and bottom chambers are not beating in concert. Normally they do. But when you have the upper chambers and the lower chambers beating independent of one another and in an irregular fashion, you lose about 15% or more of the cardiac output. I call it the cardiac oomph, and that's per beat. So just multiply that by the number of beats in a day. So these patients tend to be very fatigued. The other one is heart failure. Now imagine this: your heart is beating fast, and if it's not being treated adequately, you can develop heart failure. I had a patient recently, just a couple of months ago, who did not want to go on medications. His heart rate was like, and this guy's a pretty big guy. He was a hardworking guy and not a feeble person. And his heart rate was like 110 at rest, doing nothing. He'd go to the bathroom and be up to 130. And he was showing early signs of heart failure. I finally convinced him to take medication. But so it's another important thing is heart failure. But the one that I find most scary is cognitive decline, which a lot of people aren't terribly aware of. So people with atrial fibrillation are about 30% more likely to develop Alzheimer's disease in their lifetime. 30%. So all we need is more Alzheimer's, correct? So it's pretty scary. And also there's a strong association with vascular dimension, or small vessel change within the brain itself. So very important. So how do we treat this, and what do we do? First of all, there's really 2 types of atrial fibrillation. One is called PAF, which is paroxysmal atrial fibrillation, which means it comes and goes, usually without warning. And the other is permanent. And they both are important, because if you have paroxysmal atrial fibrillation that's at least 7 or 8 hours in duration, that's enough time for a blood clot to form in the left atrium, which can break off and go up the aorta and the carotid artery and cause a stroke. That's kind of what we go by. If it's persistent, or even if it's paroxysmal, but if it lasts for 7 or 8 hours, that's scary. And those patients really need to be anticoagulated. being a medical advocate, you want to be able to identify your triggers. Does it happen when you're asleep? It could be vagal. Does it happen when you exercise? Does it happen when you eat certain foods? Sometimes salty foods have been implicated in atrial fibrillation. Also gluten, sugar, processed foods, and of course, tobacco, alcohol, which you already mentioned. So you want to be able to identify those risk factors. And so my goal is, I would say every cardiologist's goal, and it's not so much unique to me, but we want to first slow the heart rate down. We don't want you at a heart rate of 130, 140, 150, because you won't function well and you're going to be very agitated. So the first goal is to pharmacologically slow the heart rate down, assuming when you present in the emergency room. And then the second goal is to anticoagulate you. And the third goal is to see if we can convert you to sinus rhythm. My goal always, whether it's a person who's young, middle-aged, or elderly, is to try to get that patient back in sinus rhythm, because it'll lessen the risk of stroke, it'll lessen the risk of dementia, and most important, they'll feel a lot better and will lessen their chance of developing heart failure. So I always do my best to try to get them in back in normal rhythm. Now, medications, and they can be helpful, but there's a very high recurrence rate with medication. Sometimes we do what's called a cardioversion, in which we put paddles in the patient's chest. It's a controlled situation. We put them to sleep for about 15 minutes, and it's a relatively easy procedure. It either works or it doesn't. And then there's also a procedure called an ablation, when I send the patient to an electrophysiologist, who's a cardiologist like myself, but who has special training in how to treat these arrhythmias. And it's an invasive procedure, but it can be effective. And with atrial fibrillation, it's probably about 75% effective in resolving the arrhythmia. Now, what about this anticoagulation? I'm going to end with that, because it's very important to be on blood thinners when you have the arrhythmia. And let's say we cardiovert you and we're successful in getting you in normal rhythm, or you have an ablation. How long are you on anticoagulation? For years, we didn't have this answer. Like when I was a young cardiologist many years ago, when I would cardiovert someone and get them in normal rhythm, cardiologists would monitor them for a couple months, and if there was like a normal rhythm and they haven't had any recurrences, I would stop the anticoagulation in most cases, because we didn't have any guidelines. Now we have something called the 𝗪𝗪 score, CHADS, and it's a point system. And if you have a 0 score, you don't have to anticoagulate the patient. If it's 1, it's questionable, but you don't really have to. If it's 2 or more, you have to anticoagulate the patients. So we, like age, greater than 75, that's a point. Hypertension's a point. So if you're over 75 and you have high blood pressure, excuse me, you will be needing anticoagulation for life, even if you had a successful ablation. And the recurrence rate it can be as high as 30%. So that's why it's really important that we utilize all these measures to get you in normal rhythm and keep you in normal rhythm. And if you require anticoagulation according to your 𝗪𝗪 score, we anticoagulate you. So that's the ins and outs of atrial fibrillation. And I thought it was a great way to start off this February Heart Month. So now I'm ready to take your questions. So let me put my glasses on. Okay, on the odds of Alzheimer's are kind of decline about 30%. What are the lifestyle factors that could prevent you from being in that 30%? Or is that just a stat based on genetics and odds? Thank you, Trevor. That I didn't mention, there's also one other thing, pardon me for going backwards, but there is a genetic basis for this disease, for atrial fibrillation. And I've seen it now more than ever when I see family members, but there's also a genetic marker we can look for. I use it oftentimes with Cleveland Heart Lab, and it's called 4Q25. And it's a genetic marker. And if you have 1 or 2 of those copies, it does predispose you to atrial fibrillation. It is seen in families. Okay, so lifestyle measures, what we always talk about as being your medical advocate, exercise, diet, all the things that we talk about. Those stats are based on your average. You're absolutely right. So people that, we don't want to be average, right? So, but the stats are based on the average person. And the average person isn't healthy. I just reviewed a study, I think it was at a Mayo Clinic, that 2 out of 3 people have a heart age that's older than their chronological age. That's not very promising, is it? And like I've told you in one of my other YouTube videos about metabolic health, that only 12% of the adult population is healthy metabolically. So I think it is talking about your basic patient and not us. Okay. Okay. Are there any ways to slow your heart rate without medication? Good point. If it's 150, 160, the answer is most likely no. And that's really, most patients that present with AFib are going to have a heart rate 150, 160, 170. So at that point, I would say it's pretty hard. As far as slowing your heart rate, see, a normal heart rate is 60 to 100. And I think we can lower our heart rates at will by biofeedback and also by exercising. As you exercise on a more regular basis, you are actually conditioning your heart so they can do more with less stress. But once it's an arrhythmia and it's 140, 150, there isn't much. Now, yeah, there's things that I can do. If you come to me, not so much an AFib, but there's another arrhythmia called SVT, which is very common. If you come to me in my office, I can be very successful in pressing on your carotid artery. I don't recommend you doing this at home. And that will also that will actually ignite the vagus nerve, which can help slow it down and sometimes break the arrhythmia. Other things you can do is to bear down like you're going to have a BM. We call that a Valsalva. And that's pretty easy to do. You can try that. And the other one, only I think I would be the only one that would do this one, that's stick your head in ice water. Since I'm a cold freak, and that's been shown to induce a vagal response. But keep in mind, these measures are really not going to work most of the time for atrial fibrillation, but it will for like SVT, which is a different arrhythmia, which is not nearly as dangerous and long-term as far as morbidity and mortality. But yeah, so those are great measures to use for those arrhythmias. AFib, I don't think it's going to work. Okay. Clinicians have supplementing with K2 while anticoagulants is contraindicated, but can't you still take moderate doses of K2 even if they're on thinners? Okay, so vitamin K2, what you need to know is that there's vitamin K isn't just vitamin K. There's vitamin K1, which we associate with blood thinning, and vitamin K2, which is what I use in cardiology to try to transport calcium from your diet to where we want to go, which is bones and teeth. We don't want to go into the heart vessels and the heart valves. So there's a lot being, done right now with vitamin K2. I use K2. I don't think it has nearly the blood thinning properties as K1. Now keep in mind though, this is kind of a moot point at this stage of the game because we're really not using Coumadin anymore for the treatment of non-valvular atrial fibrillation. Now we're using things called NOACs, which stands for new oral anticoagulant. You've probably heard Eliquis and Xarelto. And so these are different agents, and they don't affect the individual clotting factors that are produced in the liver, which are vitamin K dependent. But we're really talking about vitamin K1. So I have plenty of patients that are on anticoagulants, meaning the newer ones, and I use K2, and I've never had any bleeding problem. So I think you're safe to use that. Good questions. Okay, does AFib always have severe discomfort or can it be mild? Another good question. Some people don't know about it. Like once let's say you're on a beta blocker or a type of medication that actually slows your heart rate, you might not be able to tell. I have one patient, she got an iWatch. And this is right after I found that study at Stanford University. I said, boy, iWatches could be really useful in detecting atrial fibrillation. Anyway, she comes to the office and says, I'm in AFib. I said, really? She said, yeah, I didn't really know it, but I checked my watch. And she was in AFib. It happened again she had a recurrence. About maybe a year and a half later, same thing happened. She calls up, I'm in AFib. And she could not tell. So it's very interesting. So you don't have to always know. She wasn't a very active person. So I think if you're really active and you're used to being, exercise and so forth, you'll be able to tell a difference in your energy level. She really couldn't tell. But yeah, it can be mild. And if you're on a medication that slows your heart rate down, that can make a difference. Okay, good question. If you develop AFib, does it mean you have heart disease? Most commonly we do, like I said, that was the first thing, is that you should go to a cardiologist because you really want to rule out the presence of structural heart disease, coronary artery disease. Hypertension is a big cause, valvular heart disease. And so we always do like an echocardiogram or an ultrasound in these patients to make sure the heart is structurally sound. But then you have all those other non-cardiac causes. So you want to rule out the cardiac first, and then you want to look at the individual risk factors. Look at the thyroid status. Is there any lung disease going on? Do they drink a lot of coffee, alcohol, smoke? So that's kind of how we do it. Okay. Can you self-convert AFib? Yeah. Okay. So a lot of my patients that develop their first bout, they'll just sometimes just convert on their own. So that's why I don't get too crazy at my first time I see a patient in AFib. A lot of doctors, I don't get this. It really disturbs me. But these patients that are seen in the emergency room because they've got the symptoms, their palpitations, their heart's, racing, and they're uncomfortable, and they're in AFib. So, okay, so here's what the ER doctor is going to do. They're going to give them this drug called cardizan, which is an IV drug, which does help to slow it down. It will not convert the rhythm. It just slows it down. And then if they wait long enough, oftentimes the heart rate it'll just convert to sinus rhythm if it's their first bout. I see this in young people oftentimes. So I don't go out of my way and say, okay, you need to be on anticoagulations and beta blockers. I usually will follow these patients as they have ongoing symptoms or if they develop recurrences, then I'm going to be a little more aggressive. But on the first episode, unless they have structural heart disease, I'm going to usually wait. But they can self-convert, absolutely. Is your way to know it's AFib and not a heart attack? And should you go to the hospital? I would say if there's any doubt, yes, go to the hospital. Or at least, I always tell my patients that if it's during waking hours, come to my office. Well, let's do an EKG. Because you really can't always tell. I mean, remember, it could be AFib, or it could be SVT, which is supraventricular tachycardia, which is very rapid and fast, but not nearly as troublesome in the long run. And worse yet, it could be something called ventricular tachycardia, which is seen with structural heart disease most of the time, which could be potentially life-threatening. So yeah, get checked out. Okay, should you never have even one glass of wine? Well, when I read that article, and I thought it was a pretty good study from the European Heart Journal, I would really think twice. I mean, it's easy for me to say that because I'm not a drinker, but that's a chance the individual has to take. I would probably say if you smoke, don't. If you drink, don't. If you really want to cut down on your occurrence, because even if you've had AFib, and whether or not it's that particular bout was related to alcohol, definitely is going to be a trigger factor for you. And as a medical advocate, you want to be able to identify your own triggers, and one of which is alcohol. So it's easy for me to say that because I don't drink. I think it's something you have to kind of just chance. How troublesome was the AFib? Was it easy to get you a normal rhythm? And that's a lot of that has to be kind of taken into consideration. So it's an individual decision. Okay, adenosine. Okay, so adenosine is an IV drug, and we use it in the emergency room, but we don't really use it for AFib. We use it for that SV2 that I talked about because it can break SVT. I've never seen it really convert atrial fibrillation. Atrial fibrillation it's just a damn hard arrhythmia to break with medication. It's either you can spontaneously break it. There are medications we can use. One is called amiodarone, which is not exactly without toxicities and problems, but adenosine isn't really used for atrial fibrillation, but it is used in the emergency room for something called PSVT. There's another arrhythmia called a-flutter, which can be confused with SVT, but I'm not going to go there. I don't want to overload you with too much. Okay, if you could recommend just 1-2 simple health habits, change for heart health and longevity, what would that be? Wow. Okay. I would say it's going to boil down to my usual diet, weight loss, and exercise. Obesity is clearly a risk factor in those with atrial fibrillation, and that's controllable. Your diet is definitely controllable. I would stay away from processed foods. Probably salty foods that can also be implicated in it, tobacco, and, we already mentioned the alcohol. So I would say, we really want to stick to a healthy lifestyle. I really think with a healthy lifestyle, we can do a lot of this. Most of the people I see in AFib aren't extremely healthy, at least when they first came. And this, to me, could be used as a wake-up call. I like to think of that. So there's a lot we can do, and you guys know how much I'm into healthy lifestyle. So, and I work with people to get them on the right track. So absolutely, I think it's definitely workable. How can wine cause that? It's so relaxing to have it. It is relaxing, but I don't think the mechanism has been worked out. We don't know who's at risk until you actually have a bout of AFib. So I wouldn't say don't drink at all if you never had AFib. If you like it and it's relaxing, you have every month. I've been asking around, so let's do that. Okay. Get this. These are real questions, by the way. I didn't make them up. I'm a patient at Kaiser. My doctor has me on Coumadin, warfarin. That's the warfarin. Is that as effective as some of these newer agents like Eliquis or Xarelto? And the answer is no. It's not as effective. It's just cheap because it's generic, and that's often how. I can't believe that some HMOs and certain insurances still use Coumadin. Coumadin should not be used for non-valvular atrial fibrillation. So let's look at Eliquis for a minute. It's been shown to be superior to Coumadin when it comes to preventing a stroke. Well, that's pretty important. It also is superior to Coumadin preventing a bleed. That's also important because there is a risk of bleeding when you're on these agents. So it's not the same thing. Another good question: are there certain herbs that I need to avoid while on anticoagulants? Yes. I don't disallow fish oil because there's so many benefits, but anything with the G is the things you have to be careful with. Ginseng, garlic, ginkgo, and ginger. I always forget them. I have to write them down. Those four, those are definite blood thinners, and they're very good. Like garlic, I use a lot in my practice, and ginger is also very anti-inflammatory. But if you're going to be on one of these agents for blood thinning, real blood thinning, I would probably avoid those. But I don't avoid fish oil. Let's see any other questions that showed up. Does your ApoE gene affect whether you should drink alcohol? Your ApoE gene is useful for two things. I use it in cardiology because it lets me know if you have one of those, if you have, let's say you're APO4, okay, you have 1,4 allele. Even if you're 4,4 or 3,4, that increases your risk of having high cholesterol because you become a hyperabsorber, meaning you absorb more cholesterol from your gut than the average person that doesn't have that gene. It is also a gene for Alzheimer's disease. I don't know the connection, but it is. So I do measure ApoE in all my patients, as I do 4Q25 and a few other genetics. If you're, as far as the relation between alcohol, you may want to press it and say, okay, well, I'm ApoE4, okay, which does predispose me to Alzheimer's, and now I start drinking, and now I have to worry about atrial fibrillation. We know that's associated with cognitive decline. You can really take this a long way. That again, these are personal decisions you have to make. It's not written in stone. We don't have these answers yet. I'm just trying to. My role as the medical advocate is to try to connect dots to make it sense for you. You have to make up your own decision. Okay. Here's a good one. I had an episode of AFib about 4 years ago, and I was cardioverted successfully. Don't need to worry about a recurrence. Yeah, you do. About 35% of patients will develop a recurrence sometime in their life. That's why the CHA score is so important. We didn't have that when I was a young cardiologist starting off. And so some of my patients went on to develop recurrences 2, 3, 5, sometimes 10 years later. Yeah, that happened. And one developed a stroke. Most of them didn't, but it's so now we have the CHA score, and it's really helpful in stratifying who should be on anticoagulation for life and who shouldn't be, despite being in normal rhythm most of the time. Okay, what's it? Okay, I think we do that. Let me see what else is in this corner here. This is great. Okay. Is gene investigation now being easily paid by insurance? No. It's really interesting. Now, if you're with Cleveland Heart Lab, okay, which was brought up by Quest about 4 years ago, 3-4 years ago, Cleveland is really great because they have a cap on how much they will charge an individual patient. So I can get away with ordering even on Medicare patients, if we go through Cleveland Heart Lab. So now Boston Heart Lab, which is another one I like very much, is a little different, but they have it now that they'll only charge you $25 for a specific genetic test. So I order, there's about 5 or 6 that I order. I don't try to do a whole genome. I'm a cardiologist, so I stick with what I know most and how I can counsel people. But I think $25 a test is pretty darn reasonable. So maybe you end up paying, let's say I do 6 genetic tests, that's what, $150 out of pocket. But Medicare will not cover them, that's for sure. And most PPOs will not either. But it depends on what you, I think we're going to be getting this a burgeoning field is genetic, identifying genomes. And now we're getting into epigenetics, which is actually things that we can alter. So it's a big field. And I just don't have a lot of faith in insurance covering this stuff. Do I think it's useful and important? Absolutely. You know, we're having to pay more and more for insurance, and we're getting less and less benefits. I don't care who's in the White House. That's just what's going to happen. Okay. I think that's about it. We pretty much used up our time. So, all right, guys, I want to thank you so much. So stay tuned in 2 weeks. We're going to be, it's still going to be February, which will be Heart Month. We're going to probably be talking about working up a cardiac patient, how to screen patients, and more important, how to stratify patients by risk. A lot of doctors, a lot of cardiologists just simply want to, they say lower is better. The lower you get the LDL cholesterol, the better it is. And I'm going to counter that with, I don't care how low it is. What I care is about your risk. So we'll do that in 2 weeks. Thank you. Thank you so much. And good evening. Take care. It's a half hour. That's what it's down for. Had good questions, right?
You're still on
Oh,
in the stream.
no?